welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
My name is Camila. I'm a PGY2 emergency medicine pharmacy resident at Jackson Memorial Hospital. Today I'll be presenting my journal club on the 2-bag versus 1-bag method for adult and pediatric diabetic ketoacidosis management, which was an article published in the Annals of Emergency Medicine in September of 2025. So diabetic ketoacidosis, or DKA, is a life-threatening complication of diabetes and remains a major driver of hospitalizations and healthcare costs. It accounts for over 500,000 hospital days annually, with costs exceeding $6 billion. Fluid and electrolyte losses are both major contributors to morbidity and mortality in DKA, so the management focuses on identifying and correcting hyperglycemia, volume depletion, acid-base disturbances, and electrolyte abnormalities. So we can simultaneously manage electrolyte disturbances and hyperglycemia by running insulin and fluids concurrently, and there's 2 different ways of doing that. Traditionally, most institutions use the 1-bag method, which is where an insulin infusion runs alongside a single IV fluid bag that contains electrolytes, which is then switched to a dextrose-containing solution once the glucose falls below 250. This approach requires frequent bag changes and manual adjustments, which increases the workload for nurses and increases the risk of errors. The 2-bag method was then developed to streamline this process. It uses 2 simultaneous IV fluids that are identical except one does contain dextrose. The nurse will adjust the ratio of the 2 bags to titrate glucose levels in real time without ever stopping the insulin infusion. And this method allows for a smoother glucose control, fewer therapy interruptions, and potentially less hypoglycemia. The objective of the study was to put together the available evidence comparing these 2 systems across both adult and pediatric populations, making this the first ever meta-analysis to evaluate the outcomes across both. So this is an example of an adult fluid titration protocol. The titration protocols used in these studies use a similar schematic to the one that's illustrated here. As you can see, both bags contain the same electrolytes, typically sodium chloride with 20 to 40 MEQs of potassium per liter. One bag contains dextrose, usually D10, while the other doesn't. The nurse adjusts the ratio of dextrose between the 2 bags based on hourly glucose checks to maintain the target glucose between 150 and 200. More specifically, the ratio of dextrose is adjusted by adjusting the rate of each infusion. The insulin infusion remains uninterrupted, and the electrolytes are adjusted as needed per the labs and to prevent hypoglycemia. These titration protocols were also consistent with the Children's Hospital of Philadelphia and Texas Children's Hospital pathways, which also served as templates for the ones included in the studies. And here's CHOP's protocol for reference. And like I mentioned, although some large institutions, more commonly pediatric ones like CHOP's, have already integrated the 2-bag method into their protocols, the American Diabetes Association, International Society for Pediatric and Adolescent Diabetes, and the Canadian Pediatric Society guidelines, just to name a few, do not mandate the 2-bag system. Their recommendations are more so limited to changing to dextrose-containing fluids once the glucose reaches 200 to 250 and around 300 in pediatrics. So in summary, this remains an institution-driven practice rather than a national standard, and the guidelines mainly focus on when to incorporate dextrose. So now the question becomes, does the evidence actually support the 2-bag system as a better approach? So first, let's look at what previous studies have shown, starting with adults. The overall trend across multiple retrospective and before and after studies is that the 2-bag method showed faster correction and fewer adverse events compared with the 1-bag. The studies mentioned here, done by Munir, Haas, and Nolly and colleagues, found quicker anion gap closure and acidosis resolution, typically about 2 to 8 hours faster. They also showed up to a 50 to 60% lower rate of hypoglycemia. And the studies by Haas and colleagues also found 53% fewer hypokalemia events with the 2-bag protocol and fewer IV bag changes. And Cho and Adams and colleagues found that the 2-bag system reduced nursing workload. And Overall, across these studies, there was no increased risk of adverse events. So to summarize the adult data, the two-bag method consistently provided faster DKA resolution, fewer complications, and a greater workflow efficiency, with the strongest evidence coming from the two biggest studies done by Haas and Nolly and colleagues. In terms of the pediatric data, the overall trend is that the two-bag method improves workflow efficiency and glucose titration without clear differences in major clinical outcomes like DKA resolution or hospital stay. A meta-analysis by Nasser and colleagues found faster glucose titration and shorter time to DKA resolution, although the differences in hospital stay were not significant. Patel and colleagues in the pediatric workflow study both showed reduced nursing interventions and improved efficiency with the two-bag system. However, there doesn't seem to be any consistent differences in hypoglycemia across these studies, although some did note some mild increases in hypokalemia and hyperchloremia. So again, to summarize, from what we can see, the two-bag system appears to improve workflow and may even shorten DKA resolution time, though the evidence has been somewhat inconsistent across populations. So that brings us to this meta-analysis, which aimed to address those gaps by combining both the adult and pediatric data into one large systematic review. For the primary outcomes, the authors compared the incidence of hypoglycemia and the time to DKA resolution, both analyzed separately for adult and pediatric populations. The secondary outcomes included duration of insulin infusion, incidence of hypokalemia, hospital length of stay, rates of cerebral edema, and resource utilization. So like I mentioned, this study was a systematic review and meta-analysis that included randomized control trials, retrospective cohorts, and quality improvement studies evaluating the two-bag versus one-bag method for managing DKA in both adult and pediatric populations. The authors searched databases through March 2025 to identify eligible studies, and the studies were included if they involved hospitalized patients with a confirmed diagnosis of DKA and directly compared the one and two bag systems. Of the 21 studies that met inclusion criteria, 4 were randomized trials, 16 were retrospective cohorts, and 1 was a QI project, which totaled nearly 4,700 patients. Of those, 3,300 were adults and 1,400 were pediatric patients. One study was excluded due to critical bias. And of note, the authors did mention that the general composition of the fluids across the studies were consistent. For the analysis, the authors used standard statistical methods. Pooled analysis compared the two-bag and one-bag methods using risk ratios for categorical outcomes like hypoglycemia, and mean differences were used for continuous outcomes such as DKA resolution. A random effects model and I-squared statistics measured variability across studies. And finally, a sensitivity analysis excluded studies at risk of critical bias, and a subgroup analysis was performed for adult and pediatric populations separately. Now moving on to the results. The primary safety outcome was hypoglycemia. Overall, the two-bag method did significantly reduce hypoglycemia compared with the one-bag method. Adults had a 54% lower risk, and pediatrics a 38% lower risk. Both were statistically significant. And this makes sense clinically because by allowing real-time glucose or dextrose titration, the two-bag method minimizes overshooting glucose levels and minimizes interruptions. The secondary primary endpoint was time to DKA resolution. Resolution was about 1.8 hours faster overall with the two-bag system, about 2 hours faster in adults, and about 1.5 hours faster in pediatrics. And again, this reinforces the idea that smoother glucose control may help resolve metabolic derangements more efficiently. It is important to note here that there were inconsistent definitions of time to DKA resolution between the studies included in the meta-analysis. So the authors used the definition of DKA resolution as defined by the American Diabetes Association whenever possible, which includes glucose above 200, a beta-hydroxybutyrate concentration above 3, pH less than 7.3, or bicarb less than 18 in adults, or bicarb less than 15 in pediatrics. So they reported the time to resolution of these variables as a surrogate for the time to resolution of DKA. For secondary outcomes, several findings did stand out. First, in adults, the mean insulin infusion time was significantly shorter, about 3.7 hours on average with the two-bag method, and also resulted in fewer interruptions in insulin administration. And this was likely due to smoother titration between fluids. For pediatric patients, there was a trend toward shorter insulin duration, but it didn't reach statistical significance. And this was likely due to the smaller sample size and greater variability across these studies. In this study, the duration of insulin infusion wasn't considered a direct surrogate for DKA resolution, but rather a shorter duration of insulin infusion reflects more efficient resource utilization, since many hospitals do restrict insulin infusions to the ICU, so potentially reducing the need for or the duration of ICU admission. They also found that the two-bag method was associated with a reduction in the incidence of hypokalemia in adults. However, in pediatric patients, there was no significant difference overall. Some individual studies did note a slightly higher rate of hypokalemia in certain pediatric cohorts, and these results highlight differences in fluid and electrolyte management and the physiology between the two groups. And pediatrics in and of itself is a heterogeneous population, as the physiology of a 2-year-old versus an 18-year-old are very different, which is also going to lead to a difference in outcomes. For the remaining secondary outcomes, the two-bag method was linked to a slightly shorter hospital stay, about 0.4 days less overall, which was significant in pediatrics but not in adults. Cerebral edema was rare, but it did occur about 3 times more often in the one-bag group. So while it wasn't statistically significant, one could argue that that difference could still be clinically important, given how severe that complication is. Lastly, the two-bag method reduced IV bag changes and nursing workload in several studies, improving the workflow without increasing adverse events or costs. Now, this study does have several limitations. For starters, most of the included studies were retrospective and single-center, which limits its generalizability. There was also significant variability across the protocols, particularly in how DKA resolution was defined. Some studies used anion gap or bicarbonate, but these factors can be influenced by things like fluid type or hyperchloremic acidosis from unbalanced crystalloids. So really the best reflection of correction would be clearance of beta-hydroxybutyrate, which few studies did report. Pediatric data was also limited and underpowered, making conclusions in that population less certain. And then finally, few studies adjusted for illness severity or concurrent therapies. And since most centers used normal saline, the findings may not fully apply to those using balanced crystalloids. So how can we apply these findings in a real-world setting? The author's conclusion and takeaway here is that the two-bag method appears to be a safe and effective alternative to the traditional one-bag method, especially in settings where rapid titration and close monitoring are important. From a clinical standpoint, it allows for a continuous insulin infusion and a real-time glucose adjustment, which likely explains the improvements in DKA resolution and the lower rates of hypoglycemia seen in the data. Operationally, it's best suited for high-volume emergency departments or ICUs, where the workflow efficiency and reduced nursing workload are major priorities. So while this method minimizes bag changes and interruptions, it does depend on a very strong nursing education and clear protocol standardization to be effective. Looking ahead, we still need standardized national protocols to reduce variability between institutions, but to do so, some questions that remain about the management of DKA need to be answered, particularly fluid choice. And then lastly, larger multi-center randomized studies and cost-effectiveness analysis are needed to confirm these outcomes and to determine whether this system should become the new standard of care. So in conclusion, if there's anything to take away from this presentation is that in practice, the two-bag method can improve care as long as it's implemented thoughtfully with clear protocols and communication between pharmacists, nurses, and providers. And that is all I have for you today. Thank you for listening.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.